Hello everyone. Today I will be presenting a case with a suspected arteriovenous malformation. An old age lady with a past history of CVA was brought to ER, and my initial history from the EMTs suggested that patient is having a fall in saturation, and he was only having 60% saturation in room air. Initial 10-second assessment, patient was conscious, but patient was having a respiratory distress, and patient was already a status post tracheostomy patient, and so the patient was unable to speak it, but patient was able to completely obey to my commands. Then I went to the primary survey. In the primary survey, airway appears patent. Already the patient was having a tracheostomy, and the tracheostomy was patent, and the tracheostomy cuff pressure was also within normal limit. And anyway, we did the suction and made sure that the airway is patent and it is free of any mucus secretions. And then coming to the breathing, patient was having a saturation of only 70% in room air, but air entry was bilaterally equal, and so immediately I started him on O2 over the tracheostomy side. I started him on around 5 liter O2, and I kept the patient was having a respiratory distress, so the patient was in a kept in a propped up position, and I auscultated the air entry was there bilaterally equal, and also I did an rapid ultrasound lung to rule out any pneumothorax or any pleural effusion or any pulmonary B lines where anything were there, but there was nothing. So with the O2, the patient saturation has picked up to 85% with around 5 liter O2. So then I went to the circulation. In circulation, the patient was having a pulse rate of around 113. The patient was having tachycardia with a BP of around 150/90 millimeters of mercury, and all peripheral pulses were palpable. Then coming to disability, GCS was E4, VT, M6 was there with a pupil of around 2.5 mm bilaterally reactive. And in exposure part, peripheries were warm. Anyway, a warm blanket was also given to prevent hypothermia. So after the primary survey, as an adjunct to the primary survey, asked for an ABG as well as an ECG and as well as an X-ray chest was asked. And then I reassessed the primary survey. So now the patient is airway is still patent, and breathing, now the patient is having till tachypnea is there, respiratory rate of around 30 is still persisting, but the saturation has picked up to around 85% with the 5 liter O2. Air entry was there bilaterally equal. Circulation part, patient is still holding a BP of 110/80 millimeters of mercury, and GCS is also remaining same. So by the time I got the adjuncts to the primary survey, ABG was showing respiratory alkalosis of pH of 7.5 with a PCO2 of only 30, and PO2 was 50. Saturation was SO2 was 70% with a bicarbonate of 21. And the ECG was showing a sinus tachycardia, and X-ray also appeared to be normal. Then I went to the secondary survey. In secondary survey, there was no history of any allergies. In medications, the patients were already taking antiplatelets, oral hypoglycemic agents, antihypertensive, and statins. Patient was having a past history of rheumatic heart disease with a moderate mitral stenosis, and the patient is also known case of CVA with a right-sided hemiplegia, and he is also a diabetic, hypertensive, and a dyslipidemic patient. Then went to the last meal. The patient has taken patient is already on a Rayleigh tube feed. So he has taken and got an RT feed at morning 8 a.m. Then even lead to this, patient was apparently normal around past 2 days back, but he was gradually developing respiratory distress, and today morning they have taken him to a local hospital where they found to have a very low saturation, and they have referred to our hospital, but there is no history of fever, but a history of cough is present, but otherwise patient is a bedridden patient, and he was having progressive bilateral lower limb swelling for the past 2 weeks. There is history of fever, but no history of cough or chest pain or palpitation or aspiration. Then I went to the head to foot examination. No pallor, icterus, cyanosis, clubbing or lymphadenopathy was present, but bilateral lower limb edema, pitting edema is present. Head appeared to be normal, and the neck, the tracheostomy tube appears to be in situ with a normal cuff pressure. In CNS examination, patient is conscious, and the patient is able to obey completely to my command. Right upper limb and lower limb, but hardly only 0/5 power was there, but post CVA his power is remaining remaining the same like that only. While the left upper limb or lower limb also there is paresis, there is only 3/5 power appreciable in upper limb and lower limb, and bilateral plantars were extensor and pupils were 2.5 mm bilaterally reactive. Then chest air entry bilaterally equal with a saturation of 85% with a 5 liter of O2, and the respiratory rate is still around 30 per minute. CVS S1 S2 was present and the no murmurs, and abdomen was soft, non-tender, and bowel sounds were present. Pelvis and perineum within normal limit, and with the patient with possible acute onset of desaturation along with the bedridden patient, I provisionally suspected the possibility of a pulmonary embolism. So I calculated the Wells criteria for pulmonary embolism. It came to be around of 9. It is a high risk group, so around 40 to 60% chance of pulmonary embolism was there for this patient. So with this provisional diagnosis of pulmonary embolism with no hemodynamic instability, we planned the patient for a CT pulmonary angiogram and to rule out pulmonary embolism. That was the plan. And thing is that, but patient before patient was able to sit for a CT pulmonary angiogram, the patient suddenly deteriorated. The patient saturation started falling down, and so I again started the primary survey. Now again the airway appears patent, tracheostomy site is in situ, and the cuff pressure everything is normal and it is patent. Breathing air entry is bilaterally even now present, but saturation is 40%. Now I started even 15 liter NRBM, and patients since a patient saturation was still falling down, I started him on a mechanical ventilation. I connected the ventilator to already his tracheostomy site with a put him on a PCV mode with 100% FiO2. That saturation increased only to 50% with even 100% of FiO2. Then I repeated again a lung ultrasound to rule out a pneumothorax or bilateral any lung slide, but bilateral lung sliding everything was still present. Patient become progressively dyspneic. A patient at this time was in a propped up position. In your patient actually made the patient to lie down to secure an EJV, external jugular vein, but suddenly I noticed that the patient saturation suddenly started increasing when patient was made to lie down. Gradually the saturation increased up to 90%, which is 100% FiO2, and the patient also became symptomatically better. So again I went to the did the primary survey. In primary survey, patient now is hemodynamically stable, airway is still patent, breathing now he is maintaining a saturation of 97%, which is 100% FiO2 on mechanical ventilation, but this FiO2 I was able to gradually reduce with the subsequent hours. Circulation is still holding the BP was around 144 or 90 now, with the tachycardia was still persisting with a pulse rate of 112. Disability GCS is again E4 VT M5, and exposure to peripheries were warm. So I reassessed the primary survey, made sure that he is comfortable right now, and primary survey all the parameters are within normal limit. So I made a provisional diagnosis to that patient is having an orthodeoxia. So most common cause possibility of an AV malformation I suspected, and before the patient was shifted for a definitive CT pulmonary angiogram to rule out that. I did a small test that is agitated saline test. We did it in the ER itself. In the agitated saline test in the 4-chamber way, we noticed that these microvesicular bubbles, it came to not only in the left atrium and left ventricle, it was immediately it came to the all 4 chambers. It indicates that there is an AV malformation, so we were able to appreciate that. Not only initially the bubbles came in the right atrium and right ventricle, means the next 2-3 cycles it came to the left atrium and left ventricles also. So indicates the possibility of AV malformation was again more suspicious. So we did with a definitive CT pulmonary angiogram. In the CT pulmonary angiogram, it was suggestive of an pulmonary AV malformation in the right lower lobe with no evidence of thromboembolism. So our suspicion was being confirmed with a CT pulmonary angiogram. To summarize, this is a case of a patient presented with an acute onset of an unexplained desaturation patient, but he is a bedridden patient. already a status post tracheostomy post CVA patient. Initially we suspected about a pulmonary embolism, but in the ER itself patient deteriorated, but incidentally we were able to find out the patient is having an orthodeoxia, and with a lying down position he was able to maintain a better saturation, and gradually the saline agitation test, in which we were able to our suspicion become more confirming that the patient is possibly having an AV malformation, and we proceeded with the CT pulmonary angiogram in which we confirmed the presence of an AV malformation in the right lower zone of the lung. Thank you.